Seizures are characterized by synchronized, high-frequency neuronal firing in the cerebral cortex, causing temporary neurologic signs. It's important to realize that seizures are not all the florid, myoclonic jerky movements that you might think of. They come in many different forms. Seizures are organized into partial and generalized. Partial means that the seizure affects one area of the brain, and generalized means that it affects multiple areas. Partial seizures are further split into simple and complex. Simple partial means that consciousness is maintained. Complex partial means that the patient loses consciousness. Generalized seizures come in many forms. Absence seizures are most common in childhood. These kids will space out for a few minutes and then snap back to reality. Uninformed parents and teachers may think the child is daydreaming. It is characterized by a classic 3 Hz spike and wave on the EEG. Most kids will grow out of absence seizures during adolescence. Myoclonic seizures are quick, repetitive jerks of one's body. Grand mal seizures are the classic form of seizures with alternating stiffening and movement. You can think of it as the type of seizure that you normally see in the movies or television. Tonic seizures present as a sudden stiffening of muscles, and patients with atonic seizures simply drop to the floor. Other signs of seizures include tongue biting, loss of urinary or bowel control, and aura. All of these characteristics distinguish seizure from syncope. Now, seizure does not equal epilepsy. Isolated seizures can occur in both children and adults. If the seizures are recurrent, then a diagnosis of epilepsy may be made. In children, seizures are usually due to genetic causes, fever, trauma, or congenital or metabolic causes. Simple febrile seizures are very, very common in infants with high fevers, and in most cases, these kids will not go on to develop chronic seizures. So don't start them on anti-seizure meds after the first seizure. They don't need them at that point. Now, in adults, you should elicit a history of trauma, stroke, or infection of the CNS. Always rule out a brain tumor or other mass lesion in adult patients presenting with a seizure. Think of any lesion in the brain as a foci for a potential seizure. The brain itself does not have pain fibers, so a headache is a sign of irritation of pain-sensitive structures such as the dura, cranial nerves, or extracranial structures. Migraine headaches are usually unilateral with pulsatile pain. They have a variable duration, listed here anywhere from 4 to 72 hours, and are commonly associated with nausea, photophobia, and phonophobia. Some patients describe an aura, including visual, sensory, and speech disturbances. Migraines are thought to be due to dilatation of blood vessels innervated by the trigeminal nerve caused by release of neuropeptides like substance P from parasympathetic nerve fibers. Treatment of migraines can include simple ibuprofen or Tylenol, or just sitting in a quiet, dark room until the migraine goes away. More aggressive therapies include propranolol and sumatriptan, among many other medications. Tension headache is the most common type of headache. In fact, perhaps you've had one after a long day of studying for the boards. Most people don't seek medical attention for this. It's commonly bilateral, tight but not pulsatile. There's no photophobia or phonophobia. Pain generally resolves with low-dose ibuprofen or Tylenol. Cluster headaches generally affect middle-aged men. They're called cluster headaches because they tend to cluster in time. There are multiple episodes of unilateral periorbital pain that occur daily for several weeks, and then the symptoms abate for a period of time. Remember the key feature of this headache. It is often associated with ipsilateral nasal congestion, runny nose, teary eyes, and Horner syndrome. Treatment for cluster headaches is with sumatriptan, which is a serotonin agonist. If a patient without a history of headaches suddenly develops a headache, begin worrying. First and worst headaches are more likely caused by nasty things like subarachnoid hemorrhage, meningitis, hydrocephalus, and arteritis. These patients will complain of the worst headache of my life, and usually they do not have chronic headaches, or at least the caliber of the headache is different. If the presentation is more subacute to chronic, then consider brain tumors, which can frequently present with headaches. Vertigo is either a sensation of motion when there is no motion, or an exaggerated sense of motion. This is the so-called room is spinning, and should not be confused with dizziness or lightheadedness. There are several key elements in the history that you should elicit when a patient presents with vertigo. The first is how long the symptoms are lasting. Some causes of vertigo lead to episodes lasting seconds, like benign positional vertigo, while others develop over the course of months or years, such as acoustic neuromas. You should also elicit whether there is any hearing loss or tinnitus. Tinnitus, of course, meaning ringing in the ears. Auditory symptoms are more suggestive of a peripheral cause rather than a central cause. You should also find out if the patient has started any new drugs, as vertigo can be a side effect of certain medications. The classes of drugs that are most associated with development of vertigo include anticonvulsants, antibiotics, sedatives, analgesics, and tranquilizers. So, what are some of the triggers for vertigo? Right, they include the high-salt diet, stress, fatigue, changes in head position, and also bright lights. Vertigo is generally divided into peripheral causes and central causes. We'll talk first about peripheral. Peripheral vertigo is a problem with the inner ear. As stated, it's commonly associated with acoustic problems, which makes sense when you consider the proximity of structures mediating hearing and those mediating balance in the inner ear. Other supporting symptoms of peripheral etiology include sudden onset of the vertigo as well as horizontal nystagmus. Benign positional vertigo is the most common cause. It is caused when calcium carbonate stones called otoliths break free and float within the semicircular canals. The otoliths can break free due to trauma, aging, or infection of the inner ear. Typically, the patient complains of acute vertigo lasting between 10 and 60 seconds following head movement. Patients might also complain of imbalance, nausea, and vomiting. This can be tested by the Dix-Hallpike maneuver, where the patient is sitting upright on a table and quickly lowered into a supine position with the head extended 30 degrees below the body and turned rapidly to one side. This should elicit the patient's symptoms and nystagmus. Meniere's disease is classically described as episodic vertigo lasting between 20 minutes to several hours, in association with fluctuating hearing loss, typically for the low-frequency sounds, tinnitus, and a sensation of pressure from the inner ear. These symptoms wax and wane. It's unknown what causes Meniere's disease, but it is thought to be due to excess endolymphatic fluid causing distension of the inner ear. Other causes include infection of the vestibular nerve or any other component of the inner ear. Central vertigo is a problem with the brainstem or cerebellum. Central vertigo is often of gradual onset, and it's not usually associated with auditory symptoms. Unlike peripheral vertigo, which is episodic, central vertigo is often unremitting. Think broadly about the differential for central vertigo. It can be caused by ischemia to the vestibular nuclei in the brainstem, demyelinating diseases like multiple sclerosis, or tumors of the brainstem and cerebellum. The one that will likely be tested the most is vestibular schwannomas, frequently referred to as acoustic neuromas. Most often they occur unilaterally. Now, if they occurred bilaterally, what would you be thinking about? That's right, neurofibromatosis type 2. One way to differentiate central from peripheral vertigo on exam is to consider nystagmus. In peripheral vertigo, the nystagmus usually occurs after a slight delay and is usually along the horizontal axis. In central vertigo, the nystagmus, if present, can occur in any direction, including the vertical axis.